Hello, everyone, and welcome to today's webinar. As you know, we'll be reviewing the Rural Quitline Evaluation Project today. So we'll be getting started. Just a few housekeeping notes first. All the attendees are muted upon entry so that we don't have any background noises. At the end of the presentation, we will have a Q&A portion, questions and answers portion, where we'll be welcoming questions. So to do that, you can use the chat feature to write in. And then we will be able to unmute you if you have an audio question that you want to ask, or if you want to ask a question audibly. For those of you who are only able to join by phone, you can see the number there. You would call 669-900-6833, and then you would enter the Zoom ID for this meeting. Okay, so again, today we'll be talking about the Rural Quitline Evaluation Project that the Behavioral Health and Wellness Program did in conjunction with National Jewish Health. So again, just to point out the question and answer button, you can see it's the chat icon down here is what you can use to chat your questions. And Amy will be helping me to monitor those, and we'll queue them until the end of the presentation. But again, we'll allow some time for those. Okay, so just a little bit about our organization. The Behavioral Health and Wellness Program is housed in the University of Colorado School of Medicine on the Anschutz Medical Campus. And we specialize in all sorts of wellness programming around the 8 dimensions of wellness. I do want to also mention at the outset that, and I'll mention this again, our report, our final report for this presentation is available on our website, and we'll have that link as we go through. Okay, so here are today's presenters. I am Derek Noland on the left here. As you can see, I'm a community liaison at the Behavioral Health and Wellness Program. I've been with the organization for about 4.5 years now. So I do a lot of work in the tobacco health systems change field. My background is in global public health, and as part of the completion of my master's program, I had the opportunity to do an internship in Prague, Czech Republic, where I got to work with Charles University and the Czech Ministry of Health to do some really interesting tobacco-related research there. And that kind of got me interested in this topic. And when I returned to the United States, moved out to Colorado for this job. And I'd also like to give my colleague, Dr. Loha, the opportunity to introduce himself.
Yeah, thanks, Derek. I'm Thomas Olia. I'm the clinical director for health initiatives at National Jewish Health. Health initiatives is our department that operates mainly state quit lines, but does tobacco cessation in many different areas as well.
Okay, thank you very much, Thomas. And I know you wanted to provide a little bit of information about the Quitline before we proceed.
Yeah, and I wanted to take the opportunity also to welcome everyone to the webinar. We're really happy that you could join us to learn about this really unique project. And so I want to start by introducing a little bit about who we are at National Jewish, as well as how and why this project came about. So National Jewish Health is a nonprofit, non-sectarian respiratory hospital, and we're located in Denver, Colorado. And as I mentioned, through our Health Initiatives Department, we operate 18 state quit lines across the country, including in states with large rural areas. So our Quitline program offers, of course, telephone counseling, nicotine replacement therapy. We have an interactive online platform with chat coaching, text and email programs, and it's available to anybody who uses tobacco, including e-cigarettes or vaping. We also offer specialized tobacco cessation services through our pregnancy and postpartum program. We have an American Indian commercial tobacco program, and more recently, our My Life, My Quit cessation program for youth. Over the past several years, we've really been focused on reducing tobacco-related disparities and have been thinking about ways to improve how we work with different disparity populations. So, for example, people who use menthol tobacco, or LGBTQ populations, people with behavioral health conditions. And the project you'll hear about today arose from conversations that we hosted with several states, asking about how the Quitline could really better address the needs of their rural residents who use tobacco. Just for a point of reference, about 12% of all of our callers live in a rural area or a small town, so they're predominantly long distances from healthcare services or other services that they may otherwise need to access. And of course, that varies by state. So some of our states have less than 1% are living in rural areas. In other states, it's more than 25%. And so National Jewish Health partnered with the states of Nevada, Pennsylvania, and Colorado on this really collaborative Quitline evaluation project. And with our state partners and with Behavioral Health and Wellness Program, we're really pleased to share the findings of this evaluation and believe that there's really important lessons that we can all learn, in particular for the Quitline community. So thank you, Derek, for leading this webinar today.
It's my pleasure, Thomas. Thank you for that important introduction. So I'd like to reiterate again, thank you everyone for being here. We're glad to see that there's a lot of interest in this topic, and we do think that this report would be worthwhile for checking out when you have the moment. So our objectives for today, we're going to review the rationale and methods that were used for the Rural Quitline Evaluation Project. We've already started to touch on the rationale for these, for this project. We know that historically Quitline use hovers around just 1% in rural populations, so there really is a lot of need to try to improve the reach in those settings. So we're going to look through all the different components of the research that we did for the project, the different sections that culminated to inform the report, and of course we'll review our findings as well. And those findings will take the form of BHWP's recommendations based on our research finding. So we'll have a moment to explain those and present them. Also, I think it's worth noting that there were three main focuses, I think you could say, for this project. We really wanted to increase awareness of the Quitline and use of it in rural populations. So that's one of the key focuses, long-term outcomes that we're hoping to get to. We're also seeking to learn how we can maximize Quitline efficacy for those rural users. How can we make it as successful as possible? And lastly, we really want to keep identifying new and innovative ways to drive awareness of the Quitline, utilization of the Quitline, and again, ultimately good outcomes. So that's where we're coming from today. A little bit more about the project. Again, of course, funded by National Jewish Health. We began work on this back in October, and we had a few months, October to December, essentially, to collect original qualitative and quantitative data. And we'll look at how we did that in a moment. We then, poured through, analyzed the data, synthesized the results over the course of January and February, and ultimately got into the meat of the report in March. Okay, so looking at the project design here, I'm going to overview the different components of the project and the plan that we put together. And here are those different components. And again, this is a placeholder slide, and we'll be going through and looking at each of these components in a lot more detail as we go through. But here they are. So we performed a literature review of the existing evidence base, and we did use a more comprehensive approach in the literature review, in that we not only relied on peer-reviewed articles, but we also used gray literature and unpublished literature, different professional publications, things like that. So we really didn't want to limit ourselves just to the peer-reviewed evidence, simply because there's a lot more information out there that hasn't necessarily been published in that format. We also did a National Jewish Quitline survey that, of course, National Jewish Health administered. We were able to get 138 responses from people who had used the Quitline within the last year. So that was a way that we got some good quantitative data on their experiences. We also did a series of 11 key informant interviews with a number of different specialists from around the country. And simultaneously, while we were doing these projects, we also conducted a total of 4 different focus groups. And I'll look at these again in more detail as we go through, but we performed 2 focus groups with people who had previously engaged in the Quitline. So these were people who had used the Quitline and were from rural settings, and we used zip codes to distinguish between rural and urban settings. And then we also did 2 quick groups in Nevada, actually, with non-engaged rural tobacco users. So people who perhaps had some understanding that there was a Quitline, but had not used it, did not have a lot of knowledge of it, but again, were tobacco users. And so all of these results were what we pulled together and synthesized in order to form our final project recommendations. So we'll take a moment and kind of talk briefly about the literature review. Obviously, that was more extensive and a lot of detail that we won't be able to cover today, but of course that's available in the report. So again, this pulled from peer-reviewed articles, gray unpublished literature, and some of the different professional publications we used were, from the CDC, the American Lung Association, U.S. Department of Health and Human Services, some state level products as well, a lot of different things. We really wanted to be comprehensive in our search here. So I'll look to summarize some of the key findings from the literature review. I think the biggest takeaway here really is that quitlines remain effective. They're a very valuable resource. And really, when it comes to rural populations, it does seem that reaching them is the critical issue. As we know, rural populations do bear a heavier burden of tobacco. They report higher tobacco use rates, and this in turn affects them in terms of morbidity and mortality at higher rates too, of course. So another reason why this is so important. We also, in a lot of the, in some of the more specified projects that were summarized in the articles that we found in literature review, it remained clear that when projects invest in working with rural communities or really any focused community, that they can make the Quitline more effective, better recognition among those populations. So I think it's worth noting that we have evidence that this work can pay dividends. There is reason to be doing this, of course. So some of the key topics, the themes that emerged, you can see here. We looked a lot at barriers and facilitators to Quitline utilization. And there's many different factors here on both of those ends of the spectrum. And we'll look at some of those in more detail as we get into our key informant interviews and focus group results. But just to mention a few, access remains a critical barrier for rural populations. Sometimes there's difficulties with mobile phone service. Sometimes broadband connections are limited or even simply not available, perhaps in some settings. So just that simple access, getting people on the phone or using technology can be a problem. And likewise, to return to the rural population characterization, if you will, often less financial resources than their urban counterparts, and that can compound some of these problems. Another thing that emerged was the concept of enhancing Quitline utilization. So we looked at the types of things that you can do in order to drive more users essentially to the Quitline, rural users. So, things like specialized marketing, integrating Quitline information and resources and so forth into public policy, tobacco policy, those sort of things can help utilization. Kind of running parallel to that is also the theme of evaluating Quitline efficacy. Some of the things that we found are skilled coaches are something that's really sought by the participants. Medication, you'll hear me say this a few times probably, that is first and foremost the thing that people look for. The more personalization we can offer, the better, the more options in terms of services and things like that. And extending the Quitline experience is another theme that emerged, essentially making it as user-friendly as possible, finding new ways to reach people and engage them. So that's a summary of our literature review. And now let's look at the National Jewish Quitline survey that was administered. So we sent this out to people who had used the Quitline, within the last 3 months, and then gradually extended out, and we captured 138 responses from 7 different National Jewish Health Quitline states, and these were all people who had used the Quitline within the last year. In exchange for their participation, we did offer small compensation of $10 to $15, to help drive participation. So here are some of the demographic results of our survey. You can see the population that we surveyed here was overwhelmingly white, and the majority of them was women as well. So a quick snapshot of who we're talking with. We weren't able to collect some more nuanced demographic information on on these. In terms of their insurance coverage, we saw a really even mix. It was roughly split between a mix of private insurance, in most cases provided by an employer, of Medicare beneficiaries, and then about a third of the population that was either a Medicaid beneficiary or simply did not have insurance. Among this population, this was one of the questions we asked, and we saw high rates of mental health conditions and chronic diseases. So a number of different things that could qualify there, some perhaps more serious conditions than others, also allowing for behavioral health conditions, of course. So some of the things that we focused on in the survey was asking about the current tobacco use so that we could see how effective their Quitline experience had been. We asked about their access to cessation services, and we looked at their experience with the Quitline, and this was one of the most important parts. We wanted to know why they used it in the first place, which of course can help us to identify new people to contact or to reach out to. We wanted to find out what their satisfaction was with the experience and the coaches and the results and so forth. And then we also wanted to, capture some general thoughts, things that we might not have asked specifically in our questions. So that's what we were looking to receive. And so I'll highlight some of the key results. One of the things that really jumped out right away was the degree of access to support and cessation services. We found that over 90% of the people that we surveyed had seen their healthcare provider within the last year. And this really surprised us. In rural settings where it might take some time to get to healthcare provider, or maybe, also given some of the lower insurance coverage, this really was a surprising finding. And I think it really highlights, or it underlines one of our key recommendations as well, as we'll see. Frustratingly, over half of smokers were not offered any assistance. And we find this time and time again that often, even if people are asked about their tobacco use, sometimes there isn't a follow-up question. It's just allowed, that patient encounter or what have you may just continue. So a problem that continues to exist in the greater tobacco control world, and that was evident here as well. Some other questions we asked about Quitline awareness and use. And you can see there are two main buckets where people first heard about the Quitline. A little over a third heard about it from their primary care provider, and then over 40% from an ad. And as we'll see, traditional media still does resonate pretty effectively in rural settings. So, and that was a lot of the ways that they got the ads, from billboards or TV or radio. And we also asked about the reasons for using the Quitline. Again, free medication was number one. That really, for people who had used it or were just thinking about it in the case of the non-engaged rural focus groups, really the fact that medication is available through the Quitline is a big motivator. And you can see at that chart at the bottom that nicotine replacement therapy, so your gums and patches and lozenges, are overwhelmingly what people were provided. In some cases, psychotropic medications. Okay, a little bit more about the results. So of the survey we sampled, about half had completed the Quitline program, and so they were eligible for up to 5 calls, and we considered anyone who had completed 4 or 5 calls as having completed it. And there are a lot of reasons why people didn't. Sometimes it was just, life got in the way. There were time restraints, they couldn't make the calls, things like that. Other times people successfully quit ahead of time and maybe didn't need to continue in the program. Others presumably returned to smoking. So a lot of reasons why people may not have completed. Another thing that we saw was 56% had used tobacco in the last 30 days. And, while that number may seem high at first, when we think about tobacco cessation rates more broadly, this potentially is a very good result. It's challenging to say, exactly who would quit and not, but I think compared to other products and services, this represents a good rate. And that was reflected by their satisfaction with the Quitline services. We asked on a scale of 5 questions, or a 5-tiered scale about their satisfaction. And you can see the majority of the respondents chose either the 5th or the 4th tiers, the top tiers, that they were extremely or very satisfied with the Quitline. So again, that just underlines how people really do like this service, and when they're connected, will use it. Again, free medication proved to be the thing that was most important to them, and also the most satisfying component of the Quitline service. And another major finding that I want to highlight is right at the top there, that 95% of our respondents said that they would recommend the Quitline to other people in rural settings. So overwhelmingly in support of the Quitline. And you can see we asked some of their reasons why they thought other tobacco users might not use it. And I want to jump to that third one, that, you know, about 40% of the people weren't even aware of the Quitline in their, you know, in their thinking. And that really is another reason why we're doing this project, to try to bump that number up. And then there's other reasons, of course. Sometimes people just might not be ready to quit. Maybe they don't think the Quitline will help them, or maybe they have a misunderstanding about the Quitline. And we will look at that construct of misunderstanding and misperception as we go forward. Okay, so let's jump to the qualitative data that we collected now. So BHWP, our director, Dr. Chad Morris, led these key informant interviews with 11 different professionals around the country. They represented a total of 9 different states and a variety of fields. You can see there we talked to people with expertise, of course, in tobacco prevention and tobacco cessation and policy and things of that nature. And of course, people with a lot of knowledge of Quitlines. But we also talked to people who were coming at this question from a very different angle. Some people didn't really have, some of these experts didn't really have a lot of detailed knowledge about the Quitlines. And so their answers, you know, in some cases that could add value to their answers. We also looked at people who are experts in different rural health considerations, engagement strategies, things like that. We even talked to some people who were more on the technology innovation side with respect to healthcare research and education, and got some interesting thoughts from them about how the Quitline might be able to better engage rural populations. And so we asked them a series of 8 open-ended questions. We allowed the interviews to flow mostly freely, with those questions guiding it through. They took about an hour, sometimes a little longer, and we were able to go through. We, of course, recorded all these and pulled out a lot of really interesting data and quotes, too. So certain themes emerged from this interview process, and going through this, we broke them down into 6 key informant themes, and I'll overview those now. You can see the first 3 here. One of the topics that we discussed the most was barriers to using the Quitline. And as I've already started to broach the subject, there's a lot of different things in play here. Accessibility is a key one. Again, that just having access, having the phone or the resources to have a phone, those sort of things, having service. Quitline messaging was important. There's a lot of mistrust and apprehension around the Quitline, and so if the messaging isn't spot on, it can turn people off. Misperception, a really big one. People just not understanding exactly what involved the Quitline. And I'm going to read some quotes on some of these themes. So in terms of misperception, one of our informants said, "So important that people have a good experience when calling the Quitline, because everyone in town knows and it spreads like wildfire." And so the point being that, you know, if someone has a bad experience, this really can turn off a community potentially to the Quitline. Lack of healthcare provider education about the Quitline and the details of the Quitline, another major barrier. As we saw, if we can tap that resource of healthcare providers who have so many encounters with their clients, we really can drive Quitline use. Another theme that emerged was resources to support quit attempts. We had a lot of discussion about that, what sort of things we could do. One of the key things is just amplifying existing services. You know, seeing what works, a lot of which we know what works, particularly medication, and amplifying them. On that point, a quote from one of our informants was, "If we really want to make a difference, on the effectiveness side, we need to increase the amount of NRT. And that can be challenging, especially Quitline budgets are a consideration, and often NRT, typically NRT is available, but the more we're able to offer that, the better. Having different technology available for different types of people, another good resource we can use. And again, this concept of healthcare provider support for the Quitline, getting them engaged and working in our favor. One informant on that point said, we need to make it easy for providers to use, easy for them to refer people to the Quitline. And that really is the point. We want to make this as straightforward and simple as possible for providers. And another theme was, thoughts around promoting and marketing the Quitline. And a lot of things, different ideas came out of this. One strategy that seems to be a good fit is mixing of community level and broad marketing. So hitting people at different contact points. If we're able to integrate marketing into policy to the extent possible, that could be really helpful. Those sort of things. And of course, a lot of traditional marketing remains effective in rural communities. One of our informants said, our traditional media, such as TV, radio, and billboards, are still really, really powerful in rural communities. So really showing how important that is. Three more themes that emerged. One was, how do we better engage rural populations? What can we do on that front? And one of the themes that emerged, and this occurred also in the literature review, was that collaboration with local communities can be really important. One of our informants said, make it more personable, have local people talking about local issues. And we do believe that if you can get people on the ground in the community to advocate on your behalf and spread the word, that can be really powerful and just make people feel more comfortable using the Quitline. Another consideration is having a family focus for rural populations. One of our informants said, we really need hard-hitting messages that involve the whole family and focus on youth. So those are some of the key themes that we could touch on there. Specialized messaging, also important. For one, we need to be aware of framing the Quitline or along the social determinants of health theme or as a social service. People in rural settings maybe have some more conservatism, and those sort of messages might be off-putting to them. Moving on, the fifth theme here, kind of expanding upon that collaboration theme, we really do want to leverage the strengths of rural communities and use them in our favor. Typically, the theme of the tight-knit community emerged, and there's things that we could do to try to capitalize on that. I'll read a few quotes here about that concept. One, we can use the goldfish bowl effect for the positive. So taking this concept of how everything spreads so quickly by word of mouth, getting a positive message out there and having that disseminate on its own. Another quote, rural people rely on each other, so we can do our best to get them helping one another to use the Quitline. And another quote, to buy into any kind of behavior change, it's got to be coming from a trusted source. So I think all those quotes really underline just how important it is to have that community level engagement and participation. And then we also talked about healthcare lessons, from fields other than tobacco that would be applicable in this setting. Again, that concept of better integration appeared. How can we, have bidirectional supports between Quitlines and state and local level initiatives, policy level initiatives, things of that nature. One, to quote an informant, he simply said, we need to integrate Quitlines into broader tobacco control policy. Okay, let's look at the focus groups that we conducted. So again, there were 4 different focus groups in total. We did 2 with engaged rural Quitline users, and these people were identified via the survey. They were given the option to expand their participation, if you will. And then again, we'll look at the non-engaged rural focus groups in a moment. So here's the structure of the interview. We did perform them remotely using this same Zoom platform. We conducted 2 of these engaged focus groups in November. People received a $50 gift card for participation, so they did have that incentive to attend. Um, so looking at the breakdown of people that we had attend in our first group, we had a total of 3 women and 2 men show up from mountain time zone states. So I believe that was Montana, Colorado, and Wyoming that were represented in that case. And then we had a second group, ended up being significantly larger. In that one, we actually had 9 women and 2 men, so much more female dominant in that case. And this was a greater mix mostly from Eastern and Central time zone states, and 1 Colorado person too. And so all the states represented here were states that National Jewish Health Services with their Quitline. And we asked them a series of open-ended questions. We had several themes we wanted to touch about. And ultimately, these were about their experience with the Quitline and how to improve the Quitline. And those basic concepts guided it. So looking at the findings here, these are some of the themes, again, that emerged. We talked about primary reasons for using the Quitline, and time again, free medication did appear as number 1. One person said the free NRT was the best feature of the Quitline, and you know, that quote appeared in various forms time and again. Free counseling, of course, resonated with some people more importantly too. I think that combination really was the key, though, the medication and counseling together. We asked them about primary barriers to the Quitline, and maybe not for them, but their thoughts on it in general, and also their own experience. Service limitations was one. If people felt that they couldn't get enough NRT, or if they ran out of options, sometimes that would turn them off to the Quitline. Access, again, that issue of just having the connectivity and the time. And then, of course, misunderstanding and mistrust around the Quitline. And this was a really interesting concept. Some of the quotes that highlight this, one person said, the Quitline just seems too good to be true. Another person said, a lot of people think the Quitline is a gimmick. And so there was this, this thought process that, there's something hidden behind the scenes, that, there's gonna be some cost or some catch, or my insurance will be affected, all those sort of concerns, misinformation that had taken hold. Supplemental features of the Quitline proved to be mixed value. This really was kind of hit or miss. Some people really liked the technological features and automated texting and things of that nature. Others couldn't care less about it. The ability to supplement with free NRT, again, remained really critical here. Going on, some further recommendations. We asked them about suggestions for improving the Quitline. And you can see there some of the basic recommendations, of course, were to increase the availability of NRT and counseling, sometimes easier to do than others, but there is demand for those services, especially, again, the medication. There was some interest in online support groups, and perhaps the fact that we were having a Zoom online group, planted this idea, but people were really interested in the possibility of having other people on the line with them. So that was something that also came out in the non-engaged groups. Having a more tailored service to the extent possible was another thing that would really motivate people to get involved and call. In terms of the online support groups, I have a quote on that topic. One individual said, having a support group of other callers on the Quitline would help me. So pretty straightforward, but telling them what they're saying. We also got the recommendations on Quitline marketing. The theme of having real world success stories and experiences came out time and again, and building trust around that. One quote on that: there is a lack of hearing people's personal stories and successes with the Quitline. That prevents people from calling as they think it will not work. People also said things about, unsure whether or not it was an actor. All these things could potentially undermine their interest in the Quitline. Also, in terms of trust, one person bluntly said nobody trusts the Quitline advertising. So there's definitely some apprehension around that. And transparency was another really interesting theme that emerged. On one of the calls, we briefly talked about Quitline funding, and people thought it would be really helpful to know that information, with one person saying people need to know how you get your funding. So I think potentially that could help alleviate some of the problems associated with the marketing, things like that. All right, let's look at the non-engaged rural tobacco user focus groups now. So both of these focus groups were performed in Nevada in person. Again, we offered people $50 gift cards per participation, and we partnered with some local organizations in order to drive participation. So from the recruitment side, the Nye Communities Coalition and Power Room helped us to gather the first focus group, and the Carson City Health and Human Services Organization helped us to gather the second. I actually flew out to the Las Vegas area, went to Pahrump, and drove on to Carson City to conduct these. And it was a great experience to see these ideas, meet these people. Okay, so, and this was on the last slide, but the first group was an even split of 5 women and 5 men, with the second group having 9 men and 5 women, so a larger group in the second case in particular. Okay, so some of the findings and themes that emerge, we asked everyone for their thoughts on quitting and Quitline services. Again, free medication was critical. That came out time and again. Other services, maybe not as much. People had mixed opinions on phone counseling and other sort of technological features. Some people were really for them, others were not so interested. Some people expressed some interest in having really blunt, direct coaches who would challenge them and maybe even be aggressive. Universally, there's a lot of interest in the personalization of coaching, people that were experienced, trying to avoid generic coaching was a big theme that came up here. Another construct that emerged was, particularly in the first group, that people must decide to quit. There's a lot of support around that. One individual, pointed out, you've got to be ready to quit, you really do. And another said, if I'm not going to smoke, then I'm not going to smoke. So some people just thought that it was really up to them, and that the Quitline, might not play a role in their decision to quit or ability to quit. We do believe, of course, that the Quitline can help those efforts. Other barriers to Quitline utilization, I mentioned generic coaching. That was certainly a concern. On this note, one person said the coaches have got to be people that have smoked and quit. So there was some demand for having coaches who had been in their shoes. Another person said, just in terms of their general interest in the service, if you're not there with me, in front of me to speak with me, then it's BS. So some people might not be interested in over-the-phone counseling. And I think that's just a realization that we need to accept. Again, there was generally, or they did believe that low awareness and mistrust and misunderstanding of the Quitline was a problem, and so those themes remained visible here. Some other of the general open-ended comments that they made, when asked about the open-ended questions about what they thought would be helpful to them in quitting, medication definitely came to mind as a first resource. Time and again, people definitely leapt to that thought. There was also a need, people thought, for instantaneous support. If they're having a craving at night, they can call, but that might not always be the case. So that was something that people was concerned over. Potential resources that they thought might help, a video chat feature. This came up in both of the non-engaged focus groups. One person said, being able to see a person via a face-to-face app would be helpful. So that might be a way to circumvent the lack of interest in the strict phone-based feature. Maybe if this video chat feature, whether it be with a group or with an individual coach, could really be helpful. They also stress that they need a highly personalized a highly personalized approach. One person saying, give us a variety of things to help quit instead of just one option. So, the extent to which we can make that possible could help with better results. And one interesting final note, there was a lot of acceptance, even enthusiasm for tobacco policies. People surprisingly were in support of any sort of regulation that might help them in not smoking, such as smoke-free areas. People even were interested in if there were some medication that could make smoking horrible, or injections, all sorts of off-the-cuff ideas, but really a lot of support for this, interestingly. Okay, so let's look through the recommendations that culminated from all of our research. Again, ultimately, we want to maximize rural Quitline reach and awareness. We want to increase the value and efficacy of the Quitline services, and ultimately, our goal is to decrease the burden of tobacco on rural populations. So I'll quickly go through the 7 recommendations as an overview, and then go through each one in a little more detail. So here they are. Our first was promote the Quitline among healthcare providers. We've seen how important that can be. Increase Quitline trust, understanding, and transparency. We'll look at some ideas for that. Embed the Quitline in the health neighborhood concept. I'll explain that in a little more detail in a moment. Integrate the Quitline into tobacco policy initiatives. So something we've talked about, but another major recommendation here. Leverage existing technologies and explore new ones. We do think it's important that Quitlines continue to have that service so that we can reach a wide range of people. Tailor Quitline services to the individual, and of course that kind of goes without saying, it's to the extent possible, but another really important recommendation. And finally, the last one, refining marketing approaches for rural populations, really honing in and specifying or specializing some things for those populations. And of course, all these recommendations were formed based on our analysis of all the different components of the project. Okay, so let's look at that first one again. Promoting awareness of and referrals to the Quitline among healthcare providers. You'll recall that traditional providers remain a major rural resource, as evidenced by the 90% rate of people who had seen their healthcare provider in the last year. That just highlights how much of an opportunity this is. So providers need to be informed about all really the nuanced details of the Quitline. They need to know what's involved, maybe a little more than just, oh, it's a place you can call and talk to someone. We need to be able to offer some more information to our clients, including ideally information about medication, since we have seen how important that resource is. And we need to make it as easy as possible for them to make referrals, whether that's distributing pamphlets or building referral mechanisms into EHRs and their practices. Those sort of things could really make this more streamlined and effective. State funders and Quitlines could provide technical assistance. So how can we interact with the healthcare providers? How can we offer some sort of training maybe to help make this as easy as possible? Things that we can do to help them understand and promote the Quitline in a positive way. And that's a key point. Often, if someone makes an impassioned recommendation for the Quitline, they just kind of say it in passing, it's going to be much less effective than if they take the time to really emphatically recommend it and explain a little bit. And so that's really what we're going for. Our second recommendation would be to, again, increase Quitline trust, understanding, transparency, those key themes that we've talked about. We really do need to demystify the purpose of the Quitline, what it's there for, which would include, its rationale, its purpose, and its funding. I think without that, this concept of the gimmick or the trap, those sort of concepts may continue. Of course, messaging should highlight any free medication, since we've seen how important that is to driving people to the Quitline. We do think that having some personal stories really can drive trust and decrease suspicion. We saw that time and again in the different focus group thoughts. If we can get real people to spread the word, that can really be helpful. And local champions and community level advocacy is really important. If we can tap into those resources and get them speaking on our behalf and in our favor, that can lead to positive word of mouth coming from a trusted source and really start to spread the Quitline message. Okay, so another recommendation was, again, to embed the Quitline within the health neighborhood concept. And really briefly, the traditional health concept is a person sees their healthcare provider for their healthcare needs, and that's about it. But as the healthcare landscape shifts, we're seeing more and more value in the health neighborhood concept, where people engage not only with their healthcare providers, but non-traditional providers, including lay providers, community health workers, and things like that. And you can see the bubbles of all the different, just not even comprehensive, but a list of some of the key settings that might be able to accomplish this in rural communities. Faith-based organizations came up prominently time and again. Schools, another big one in rural settings. Any sort of local business or civic organizations. A lot of these settings, sort of informal hubs of care, if you will, have increased their ability to play a role here. And if we're able to empower them to the extent possible to do this, we can really expand our reach into these settings. This will also, of course, have the effect of leveraging that tight-knit nature of rural communities that we've talked about. So essentially finding out where people congregate, finding out who they listen to, how do we integrate into those settings, and then kind of let them spread the message, if you will. So our fourth recommendation was to integrate this Quitline into state and local level tobacco policy initiatives. And one of our key informants really pointed out how, historically this just hasn't happened very often. Quitlines have operated independently, but there really is an opportunity here for bidirectional policy support. So, if state and local level policies, include and market and drive people to the Quitline can likewise support policy initiatives, helping people to quit so that policies, are able to be rolled out more seamlessly. And these sort of relationships can help further the health neighborhood model that we just talked about. The more integrated these things get, the more reach we might be able to have here, and the impact can be greater. Okay, our fifth recommendation is to continue to leverage technologies, those that exist, and to be on the front line of exploring new technologies that resonate with people. These features remain important, and we saw that for some people, not as much as others, but still, there's a lot of demand here, whether it be potentially the video chat feature. There's a lot of interest around that. Some people really liked the automated text messaging as kind of a support. Others found those things triggering, so it really is being able to personalize that to the extent possible. Access points can be a big piece here, potentially distributing phone cards that people can use exclusively to call the Quitline, maybe building a Quitline kiosk in those community hubs of care, or even chain restaurants or things like that that have broadband internet access. We do see that telehealth is a growing opportunity in rural settings, and in some respects, the current pandemic has really elevated the importance of that and shown how effective it can be. And so we might be able to continue to capitalize on that going forward. And I think it's important that Quitlines become early major adopters of technologies as they emerge and remain, relevant and in the cutting edge. Okay, and tailoring Quitline service to the individual is important. And for that, really, Quitline coaches need to have a diverse skill set. So have well-trained coaches. Essential training could include motivational interviewing practices and clinical skills to help drive behavior change. Also training on different rural challenges that might be unique to rural settings as opposed to urban settings, making sure that Quitline coaches are aware of those. We really want to avoid direct scripts and being overly formulaic. That came up time and time again. And the more coaches are skilled and trained, the more they'll be able to, adapt their approach to the individual. And that really is the final point here, personalizing services and combining that personalization with what will be the best technologies for that individual. And so finally, refining marketing approaches for rural populations. We do want to have messages that are focused specifically for those settings. We saw that themes of family and self-sufficiency and resiliency, consideration for youth, all those themes might be better received in these communities. And again, going down to that fourth point, if we can collaborate with rural communities and also with our local and state level initiatives, we can amplify this even further. We do want to be aware of rural conservatism in our marketing. And finally, it's really important to recycle previous successful campaigns. You know, if something was effective, there's no reason to move on to a new one if it's still working. So to sum it up, our project conclusions: Quitlines remain a critical and effective service, specifically for rural populations as well. And frankly, they're a vital service in these geographically isolated and perhaps less economic resource settings, important service there. Reach remains the #1 challenge, perhaps coupled with the concept of mistrust and misunderstanding. And really the key opportunities for Quitline improvement, to boil it down even further, you know, better integration into the structures and policies that exist and you know, healthcare provider settings and so forth, and increasing trust and understanding, more nuanced marketing, and more than anything else, maybe really maximizing user touch points so that, you know, people have good experience with the Quitline, and that word of mouth is able to move forward in rural communities. And so that is the presentation, and we do have time for some questions, and I'm going to come on the line so you can see me here, and we'll welcome any questions.
So Derek, if I could draw your attention to the chat,
Okay.
Sean commented that we are working on education training providers every day. We'll be running social media and ad campaigns targeting providers, making sure they can and know how to refer Quitline. And people have commented that they're interested in the messaging to target providers. Do you have any examples, or can you share any more information around that topic?
I don't have any examples handy. To kind of reiterate what I said before, I really think that, you know, providing them with the details of what the Quitline in their state is offering is going to be really important. And maybe pamphlets and brochures and, you know, documentation that they can use and give out to people and rely on themselves could be helpful. And Thomas, if you have anything to add, I certainly don't want to speak over you, so please jump in if needed.
No, I think that's a good point, Derek. And you know, and I think in some ways it's at the state level, there's a lot of differences. A lot of times there are different types of networks in different states in terms of how they can connect with their providers. So I think that's an important component of it as well. I'm just reading here in the chat. It looks like there's been a few examples of how people have been accessing providers. So certainly, you know, I think those are all great ideas. Things like connecting with your state Office of Rural Health, you know, really focusing on provider network referrals, those sorts of things. I think those are all really great ideas, and would love to see more as time goes on of how people are reaching providers.
Great, thank you.
So we do have a question regarding the availability of NRT. Do you provide combination therapy? That's a question from Cheryl.
That's another situation that would vary based on the state and the Quitline provider. You know, some states have much more robust coverage than others. Thomas, I don't know if you have anything to say specific to National Jewish Health on combination therapy. And for those who don't know, combination therapy would be using more than one tobacco cessation medication at a time, so in combination.
Yeah, so we certainly, our coaches recommend it, even if a state budget doesn't allow for you know, multiple products in a single order. And I would say, for example, limited to NRT starter kits, 2-week supplies, those kinds of things. Our coaches are, you know, because the evidence is that combination therapy is most effective. So we are always recommending combination therapy. So even if we're not able to provide it through the Quitline program, we're encouraging people to, you know, access their insurance benefits or other resources where they may be able to access or get another form of NRT.
That's a great point. We really want people to take advantage of whatever resources they already have available to them, sometimes which they're just not aware of.
So we have a question from Bill. Where are the Quitline operators located who answer calls from Wyoming?
Well, I can answer that one, Bill. National Jewish Health is the Quitline operator for the Wyoming Quitline. So we are located in Denver, Colorado, but we have people kind of scattered around the state and a few coaches who are out of state as well.
Okay, and then we have another one. Oops, it keeps moving. Maria says that she's, curious about the video chat information. Given the Quitline users interviewed expressed interest in the mode of service, how do cessation coaches feel about video chat or telemedicine?
Yeah, I can't speak to how the coaches feel about it, but this concept came up a lot, even with the people who had not engaged in the Quitline. They really, came to this idea on their own, especially perhaps if I generalize some of the younger people. So that could be something that would be effective there. Um, as for the coaches themselves, Thomas, I don't know if you have anything to add on that. Oh.
It's a really good question, and it's a topic that keeps coming back around, especially as more and more people become familiar with things like Zoom and FaceTime and those sorts of things. I would say it's a challenge. So there's several components to it, right? You need to have the technology and the infrastructure so that people have access to broadband, internet, which they really need to be able to stream live video. There are confidentiality protections, especially under HIPAA regulations in terms of who and how you can provide information over video in a healthcare interaction. So there's lots of considerations to think about. It'll be interesting to see as a Quitline community how we implement these sorts of recommendations around video chat, and is it applicable for all populations? Is it a subset? Who really does video chat work for?
Any other questions that came up, Amy? Sorry, I haven't had a chance to scroll through them all myself.
Yeah, here's one. Well, there is a question. Will slides and the videos be provided, the recording be provided to participants?
Yes, I'm happy to say that they will. If you see on your screen, we have a link to our Behavioral Health and Wellness Program website. That's the landing page where the National Jewish Complete Research Project is housed. So you can go on and download that report if you like. We are recording this webinar and anticipate having that up on our website and YouTube channel within a couple of weeks. So we can send out notice to those who've registered and are interested. So yes.
Okay, great. And then there is a question, were there specific suggestions from the tobacco policies that participants spoke of more that support their ability to quit and stay tobacco-free?
I'm trying to think if we had some people talking about, I mean, we do know that sometimes people check in with the Quitline to try to, fight off cravings or maybe lapses in tobacco use, a lapse being distinct from a relapse in that the person, has a slip up as opposed to returning to sustained use. As for the ability to stay quit, that really was kind of embedded in some of the other questions. We didn't ask specifically about that topic. I hope that answers the question as best I can. Any other questions?
I don't see any more questions.
Okay, well, I think we're right at an hour. So just want to thank everyone again for tuning in today and for your attention and your questions. We definitely appreciate your interest. And on behalf of the Behavioral Health and Wellness Program, we definitely encourage you to look at the report. All right, if there's nothing else, we will adjourn. Thank you, everyone.